Welcome, everyone. We're just going to give folks a few minutes to join before getting started. Welcome to all the folks who've joined. We're just going to give everyone one more minute and we'll go ahead and get started. Okay, that's my cue. Welcome and thank you to all of you for joining us for this webinar brought to you by the Lawyers Committee for Civil Rights Under Law. My name is Natasha Chepria, she, her, hers, and I'm an associate counsel with the Lawyers Committee for Civil Rights Under Law, where I focus on our economic justice project. It's my absolute privilege today to moderate this panel. We've got a fantastic lineup, but before I get to that, let's start with some housekeeping. As we give people a few moments to log on, just want to remind everyone, if you're on Zoom, there is a question and answer function at the bottom of your screen. Please feel free to put questions in there and we'll try our best to answer them throughout the webinar. There will be an audience Q&A portion at the end where we'll give our panelists a chance to answer your questions if they haven't already been addressed. If you'd like to view the closed captions throughout the event, you can turn them on by clicking the icon at the bottom of your screen. And if you have any issues, please put them into the chat. And finally, if you'd like to receive updates about our work at the Lawyers Committee, please, we implore you to visit our website. We're working on updating it and there's a lot of really great work on there. I also just want to mention that our president and executive director, Damon Hewitt, was hoping to join us at the start of this webinar, but we might have to wait for his remarks till the end. He is currently testifying before the Senate Rules Committee about election administration, another critically important issue that we work on at the Lawyers Committee. So with that, I would just like to take a moment of reflection and honor. We know that white supremacist violence is not new to this nation, but in light of the recent violence, I just want to take a moment to honor the lives of those who were lost. Thank you all. So with that, I'll take a collective breath and let's dive into the wild and wacky world of data. So as I mentioned, we have an all-star panel of experts here. I'll tell you a little bit about them, but their accomplishments could go on for pages, so I'll keep it short. We have Dr. Ebony Hilton, She is an associate professor of anesthesiology and critical care medicine at the University of Virginia, as well as the co-founder and medical director of Goodstock Consulting, an MSNBC medical contributor, a children's book author, a public speaker, and a community activist. So she pretty much does it all. Her focus is the intersection of health disparities, particularly as they pertain to race. And really, her studies have focused on bridging the gap between physicians and patients. We also have Ben Duvanzo, who is Senior Health Policy Analyst with the National Immigration Law Center. Ben works on access to healthcare and healthy lives for low-income immigrant communities. Through advocacy, relationship building, and analysis, he advances policies that enhance the health of immigrant families and works to block those that bring harm, with a particular focus on federal legislation and executive action. We also have Adam Badawi, who is the DC Policy Manager for Access Community. Adam is the proud son of immigrant parents from Syria and the Dominican Republic. At Access Community, he brings the Arab American voice and perspective to federal policy, particularly in areas like healthcare, education, and immigration. He's passionate about understanding how power is distributed and reproduced in contemporary American society, and tailors that understanding towards a pursuit of the goals of Access and its national institution, the National Network for Arab American Communities. And finally, we have Pilar Whitaker, who is counsel with the Economic Justice Project at the Lawyers Committee for Civil Rights Under Law. There, she focuses on eradicating systemic barriers to economic mobility for communities of color by employing cutting-edge litigation strategies and engaging in advocacy and outreach. Pilar focuses on health equity, including access to reproductive and maternal health care, consumer protection, and employment discrimination. So with that, I'm going to go ahead and get us started. We have a jam-packed program today. Let's start with a lightning round. So I'm going to ask each of our panelists in a quick 1-minute blurb, tell us, how do you define equitable data? We're here talking about data as this racial justice tool, but let's start with the framework. What does equitable data mean to you? So we'll start with Adam, then we'll go to Ben, Pilar, and finally ending with Dr. Ebony.
Yeah, thanks, Natasha. Really excited to be here with everybody and to take on this kind of question. I agree, it's sort of a foundational part to this conversation. So I would say that in this context, equity should imply a relationship of reciprocity between the community being observed in the data and the observer collecting that data. Without that sort of reciprocity, where the observed feels a sort of stake in the society in which their data is depicting, data collection is nothing really more than surveillance. And so representing the Arab American community, the broader Middle Eastern and North African community, our community does feel quite represented in surveillance systems historically, particularly and probably exclusively in law enforcement agencies, but not in socio-demographic information collection systems. So to collect and report equitable data would imply that governments are making good on their responsibility in a relationship of reciprocity with the communities being observed.
So, hi, thanks for having me. I really appreciate that the Lawyers Committee has engaged in this work that really is so important. And that really is important because of my answer to this question, which is equitable data is data that doesn't just find information, but can be used in meaningful ways to address disparities. So that means looking at the policies that are kind of identifying which data is collected, why it's collected, where it's collected, and ensuring that those policies are not just towards an end of having data for the sake of having numbers, but for the sake of having numbers that are intended to change policy that are driving the disparities that are revealed in the data. So that means thinking through what types of questions are being asked and the possible answers. Who is doing the data collection? How are the answers being made available, and how is it being analyzed? And are the questions being asked in a way that means that the data reflects communities' needs, not just the needs of the researcher or of the government agency? And so in order to have data that is truly equitable, you need to have data collection standards towards a goal of not just data, but towards actual policy change and achieving and addressing disparities in healthcare.
Thank you, everyone, for joining us today. Kind of building off of what Ben just said, for us at the Lawyers Committee as civil rights attorneys, data, the equitable data would be data that actually captures the lived experiences of communities. So that means data that goes beyond race and ethnicity, but data that speaks to people's employment status, their employment type, their pregnancy status, their disability status, their LGBTQ identities, their housing status, and in doing so looks at communities through an intersectional lens, recognizing that race and ethnicity are not the only markers of people's identities, and nor are race and ethnicity the only markers that inform people's experiences as they move through society. And this is especially true in healthcare. And so for us, equitable data is comprehensive and all-encompassing.
Yeah, and I'm not sure what else to add to that. I mean, I think when I think about equitable data, I think about looking at factors that are rigid and fluid, these social facing influencers that impact outcome, but should not, right? And I tell my med students, the thing is with this data, it's like disease processes. You can have many different symptoms of a single disease. And until we actually find the root of that disease and target that, we won't be helping the person to live a fruitful, happy, healthy life. So, so when I think about this and the different ways that disparities kind of present themselves, my thought is, what's the root of that disease? How do we use that data to identify that? And typically it targets the policy, the person, the politics, poverty, and privilege, right? Because we know that disparities, it uncovers both the richness of some communities and the deprived states of others. So yeah, using that as a tool so that we can make things better for the future generations.
Thank you all so much. So the audience has gotten a tiny taste of your brilliance, and we're really going to dive in a little bit deeper now. So Pilar, I'm going to come back to you. So a lot of this work for the Lawyers Committee really stemmed from some of the work that we've done that's going to come out in a report someday soon. So can you talk to us a little bit about how we developed this work? And then taking a little bit of a step back, why is equitable data collection a racial justice issue, and how can we use it to advance civil rights?
So many of you on the call may know or are surprised to learn that the Lawyers Committee has been interested and working on this issue of data collection. And it really started at the beginning of the pandemic. Learning that the states and the CDC even were not releasing data on who was getting COVID. And I don't know if anyone remembers, but there were myths going around social media that Black people couldn't get COVID those early weeks. And obviously we learned that was not true. And a large part of that was because of the misinformation that freely flows when there is no data. And so the Lawyers Committee started to send letters to the states, to state public health departments, to the CDC, asking that they release equitable data. And we did it in conjunction with a group that Dr. Hilton is a part of. It was a collection of Black physicians from around the country. It was over 100 of them who lent their voice to the necessity of collecting this data. And that's where we really got started. And part two of that was analyzing the data. Not from a public health perspective, but just from a social perspective. What data were people collecting? And it turned out not a whole lot. That's where Ben came in to really help us advocate for disaggregated data. And generally, when we talk about disaggregated data, we're talking about data that is disaggregated into racial and ethnic subgroups. So not just saying Asian, not just saying Black, but really representing all the communities within that. But then for us, really wanting to disaggregate data even further. So looking at these various social markers, like as language, because we know that language impacts people's abilities to access healthcare. Pregnancy status. We wanted to know what percentage of women or people who were pregnant were getting COVID, were dying from COVID, were there disparities there? We know that people living in crowded housing were more likely to experience infection and severe illness from COVID. And so we wanted to disaggregate data even beyond race and ethnicity, and that's really what we've been focused on. So for us as civil rights attorneys, data really can be such a useful racial justice tool, not just because it's tracking the race and ethnicity of people, but because it's tracking their experiences throughout society, and providing useful information that providers and healthcare systems, that government officials, that policymakers can really use to affect change.
Thanks so much, Pilar. So Ben, I'm going to come to you now. So as Pilar talked to us a little bit, disaggregated data can mean a whole lot of things. So can you talk to us about why is it so important to collect disaggregated data, and why do gaps in data collection even exist?
Thanks. And for context, right, my background is I've worked across a variety of different populations and issues on health disparities and health equity. Right now, my organization, National Immigration Law Center, we really work on health disparities for immigrants who have their own kind of unique data needs that I will probably get to. But really more broadly, if data does not exist, then you do not have a policy problem. When I go and meet with congressional staff or staff for the Department of Health and Human Services, if they do not see data for a problem that's happening, even a problem that communities know and experience, and we can provide stories, but if you're not showing data that there's actual trends, then odds are the government is not going to respond to it. And so disaggregated data and data on racial disparities, but also data on gender disparities, data on disability disparities, on language disparities, means that we cannot really achieve change in outcomes, and we cannot really truly address health disparities because, unfortunately, the way that our system works, and there's a lot of reasons to critique the obsession and need for data, which is often tied to feelings around scarce resources and kind of a scarcity mindset. But that, as it may be, we know we cannot achieve in this kind of current state of things policy change without data. And disaggregated data in particular is so important because we know that people do not live in identities that are monolithic. There is no one who is just Black or just white or just Asian. People's identities are very complex and people's identities are nuanced. And disaggregated data means collecting and recognizing that, and in many ways honoring it. And so what I mean is, for example, from the perspective of Asian Americans, right? Asian American is a term that has been around for several decades now, and really came about through the history of civil rights work among Asian American communities and the kind of collective cross-unification of an Asian American advocacy movement. But really what it has come to be in terms of data is an aggregation of people who have a variety or come from dozens of different countries, speak over 100 different languages, and have many, many different types of healthcare experiences and healthcare needs into one group. And so when we see that the standard is to just ask if someone is Asian American, and that's in some ways the best case scenario, right? That's asking in the kind of true kind of following the federal standards, and not asking if someone is Asian American, Pacific Island, or even asking if someone is non-white. If you're in that case scenario in many circumstances and in many ways, which we saw pretty frequently across every level of COVID data collection for testing for vaccinations, then you are disguising the experience that people who are South Asian or Indian American have very different health care outcomes and healthcare needs and disparities than people who are East Asian, who might be Chinese or Japanese or Southeast Asian, from people who are Laotian or Vietnamese. And so this experience and this need for data that is disaggregated really reflects this kind of diaspora of people's experiences. And the reason these gaps don't exist is because it has not been prioritized, frankly. And it is not one person, there's not the kind of one evil genius who's saying, we're not going to collect the data at the federal level. In fact, this is systemic. And when we talk about systemic barriers, that means they're really hard to unravel, but it also means that we need to invest a lot of resources in addressing them. And so think about yourself, and when you last went to the doctor and you got that clipboard with a piece of paper maybe, and it maybe asked you about your race. And did you kind of choose to select it, or are you having a busy day and you kind of decided not to fill out that demographic data? Or maybe you legitimately are afraid of providing demographic data because you're not sure how it will be used by the doctor. Or maybe for some people, you don't believe that race is real or that racism is real. And, filling out data on your identity is just kind of a government conspiracy. There are a lot of reasons why someone might not fill that data out at the doctor's office. Or maybe it's the doctor who's filling out the information and they're the one at the clipboard and it's supposed to be filling it out for the patient. But the doctor doesn't feel comfortable asking about someone's race data, or they haven't been trained. Or maybe they're also too busy and they decide to skip it. They don't understand why it's important. And that's just the first level. And that is just a decision by a person whether or not to fill out the data. That's not getting to what questions are being asked. That's not getting to whether the information is being entered by the administrative staff. That's not getting to whether the system is even designed to accept demographic data or disaggregated data. And all of these decisions down to the individual level about how we kind of address race, both from a provider point of view, about the labs, about the public health departments that are collecting this data, means that every level of data collection up to then the top, where we have very low rates in many states and at the federal government of data on vaccinations by race, on COVID tests by race, then we end up with pretty poor outcomes in terms of reporting on people's race. And this is just talking about race, right? Did that questionnaire ask you about your sexual orientation? And if it did it include the correct swath of identities that people have for sexual orientation or for sex? Did it give you an option for non-binary or other, or did it only ask for male or female? Were you even asked about disability status? These are really going to the fact that we have intersectional identities, and disparities are experienced very intersectional. Trans women of color are among experience the highest disparities in data in terms of health outcomes. But if we're not collecting that data, and if we're not asking people questions and they don't feel comfortable, or the providers don't feel comfortable asking that data, or the systems aren't set up to ask for it, then we're just not going to see the data in the first place. And I think I'll get to a little bit later, that's just collecting the data, right? That's not even analyzing or reporting it. And so this is how we come to today, where the reasons we don't have disaggregated data are very connected to the reasons we have racism in our country, or we have transphobia and various other kind of biases and harms to people, very same reasons why we don't have disaggregated data.
Thanks so much for that overview, Ben. I know as a South Asian individual, I'm always confused about which box to check. So this is a very real thing that we face every single day in the minutia of our daily lives. So now I'm going to turn to Adam. Adam, what are the impacts of being part of a community that's often not reflected in demographic data? And how does that impact resource distribution and just your own community's self-perception?
Yeah, thanks, Natasha. And yeah, no, Ben gave a really good kind of framing for this conversation. There are a few places for us to really focus. One, you mentioned resource distribution. There are a number of programs that the federal government administers that make an effective cross-reference to the minimum standards for data collection on race and ethnicity. Ben offered us this history. We can even take specific dates, like if you want to go back to the post-civil rights movement development of common definitions and common terminology for collecting data on racial and ethnic groups. You go back to the mid-1970s, around the same time, in fact, our community is beginning to immigrate to this country in broader, larger numbers as a result of the removal of the national origins based quota system. So while we're sort of trickling into this country, we're developing a system by which the social world is understood with respect to these minimum data collection standards that don't include our communities. So then you have programs in the public health service, the Small Business Administration, Treasury Department that are trying to understand where the gaps are in resource distribution, basically, where the healthcare needs are in the broader public, but they're not looking for Arab Americans or people from the Middle East and North Africa, because they're not included in those minimum data collection standards. So we can take a specific example. The statutory definition for racial and ethnic minority group has been amended over time, and each time it reflects those minimum standards that the Office of Management and Budget collects, or I guess mandates all federal agencies collect at a minimum. And right now, for instance, you can look at a bill like the Health Equity and Middle East and North African Community Inclusion Act, which Congresswoman Rashida Tlaib introduced earlier this year, that would amend that definition to reflect Middle Easterners and North Africans. But at the same time, we still don't have a data collection category for the MENA community. That did kind of go to the 1 yard line in the prior to the 2020 census, but the Trump administration decided perhaps they had other priorities. But this is just one example of how our understanding of minority health concerns or health disparities is limited by these kind of minimum data collection standards, what the federal government allows themselves to understand at a systemic or structural level. So one kind of more provocative example of the opportunity cost to this system, we can just take the pandemic as a really good example. We had cases in NAC, the National Network for Arab American Communities, where a lot of our community-based organizations were administering vaccinations, doing outreach and education for their communities, and taking data for themselves about their efforts, the efficacy of their efforts even. None of that was really reflected in state or county level, state level, and of course federal level information collection systems. So you had some, I would say funny, but they're not that funny, incidents where the state of Illinois began collecting data on vaccination rates among the MENA population, and they came up with, then there was like 40 MENA individuals had been vaccinated, whereas one of our organizations was like, they were like, we did 40 vaccinations like today. We have information on how many members of our community have been vaccinated, and we worked with the Illinois State Public Health Department on the establishing a MENA category, and they see how those systems don't speak to one another. And so, of course, when it comes then to the federal government distributing resources to ensure that they can bring up vaccination rates where necessary, the needs of our communities go relatively unheard. So Ben also spoke to this point about the way that advocacy works at this point, for better or for worse. When, we have a community-based organization, for instance, flag for me something they're hearing on the ground, and then I have a meeting with the direct representative, let's say, of that community-based organization, I can say exactly what I heard from a mother, a client, whatever the case, and they'll say, they'll basically ask me where that experience exists in the data, whether it's edified in the data, and it's not. But that doesn't make it any less real, right? It doesn't mean that mother's experience didn't actually happen. So yeah, there is this other impact where not only are resources not coming to ground, but there's a sort of a statistical gaslighting that's happening, where our community doesn't really see itself reflected in many of the debates, policy debates that were we to be included. Number one, we probably see solidarities between ourselves and other communities, and then also we'd see resolution to longstanding problems within our community. So yeah, the impact is like multiplicative, and so I guess why it's important for us to reach out to communities is to sort of close this gap, to educate them on what opportunities still exist for them to make their voices heard in lieu of their data being collected, again, as I alluded to earlier, in a relationship of reciprocity. Because like I said, we are quite represented in other aspects of the federal government when it comes to, particularly post 9/11 surveillance and law enforcement authorities. We feel very seen, let's say. There are other areas, right, where us being seen would stand to benefit ourselves and stand to benefit the communities in which we reside.
Thanks, Adam. That's a really valuable perspective to bring to the forefront. So as you mentioned, it's often a set of voices that are left out of a very critical conversation. So that sort of leads me to Dr. Hilton. You're on the ground every day as a provider. Can you talk a little bit about why equitable data is so important for the medical and public health community, and how you've sort of seen data used in the medical setting?
Right. Well, for one, I think it's important not only for data to be collected, but for it to be publicly facing, right? Because then we can have accountability. And I think that's the problem. When we went into this pandemic, immediately I started to write, I think actually Pilar and her group and say, we're going to have racial health disparities associated with this before any data was being released by the CDC. And we wrote the CDC demanding that data be released to tell us who are you testing and who's actually being diagnosed with COVID, because it was as obvious as the sky is blue that was going to happen because of historic knowns. And so I think when we're looking at even the police reform right now, the reason why there's such a move towards holding accountability to police officers is that the general public knows what happens. But I doubt that the general public knows that Black and brown communities, they experience air pollution at 60% more than what they actually produce. I doubt that they know that 40% of all school districts had 51% of their HVAC systems that needed to be replaced in the middle of this airborne pandemic that still has not happened. And is that the reason why Black and brown children are 5 times more likely to be infected and hospitalized from COVID? Do they know that if you're in a public school, on average, 2 children in every public school system in the United States of America has lost a caregiver, either a parent or their grandparent that was taking care of them and are now orphaned? Do they know, these statistics? Because if you did know, that should cause some outrage, right? That should cause you to want to do something. And so the problem I have with the medical institution, and that goes from policymakers of CDC and all the governing bodies down to the healthcare systems and down to individual providers, is that we've known these same disparities have existed for generation after generation after generation. Black women, we have been more likely to die, and we're even more likely to die now than we were 15 years before the Civil War. All right, at this current state in DC, 90% of Black our maternal mortality is Black women. Right, this is a very widely known thing. Why has nothing happened? Right? Why is it that we're still saying, well, okay, if they die, it's okay that Black people have a 67% higher mortality rate when adjusted for age than white Americans during this pandemic? Why is that okay, right? So I think if the general public knew these numbers, if they knew the fact that Black women had higher mortality rate for breast cancer in every single state of the United States of America, that we die at younger ages in every single state of the United States of America. But when you think of breast cancer awareness, you imagine a white woman's face, right? There's something wrong with that. And so if we made this more public facing and said, why is it we have industrialization then? Because that's the root cause again, right? Don't talk to me about the symptoms of why we have cancers at higher rates of colon, lung, breast cancers in our community. Let's talk about this air pollution. That's the root of the disease, right? That's what's causing this. Let's talk about the water pollution and the fact that we still have lead water in Flint, Michigan, and throughout South Carolina too, right? Let's talk about the root of these problems. But if you know what the symptoms are, if you know the hard facts of 43 children being diagnosed with cancer a day, if you knew that, then maybe that will drive you because it'll touch on your emotional strings. And so we can have some accountability tied to the data to say then policymakers, how are you leading this initiative to clean up the air and water supply of these communities, right? Because it's not a problem in my gated community. I don't see bellows of smoke, but I do over here. How do we have not only policymakers on the federal and the state level, but then also how are we talking to our healthcare system to say your demographic of patients around here are living in poverty? You're the #1 employer of this city. How are you actually giving back? right? Who are you supporting in these political campaigns, and whether or not they're cleaning up the systems that be. Because if we get to that level, if we start to give out report cards, right? If we start to look at individual outcomes along the lines of each individual provider and whether or not you treat this person versus this person different, the same way that we do police officers, then maybe we can start to push this needle. So again, I don't think it's just the data collection. It's what do we actually do with it, and how do we give it to the people in digestible forms so that they can actually be, champions on the grassroots level.
Yeah, that makes a lot of sense. We need to turn all of this into action, right? So we've got about 20 minutes left. I'm going to come back to each of you with some follow-up questions because you've all given us some really good things to think about, and then leave some time at the end for you all to give some recommendations, some calls to action. So Dr. Hilton, you have talked about some really exciting stuff here, and your perspective is so incredibly valuable. In our prep call, I know we were talking a little bit about some of the ways that you see these disparities reflected and sort of perpetuated through various pieces of the medical institution. Can you talk a little bit more about some of those pieces? Particularly, I know you mentioned getting things approved through the IRB. So I'd love to know how it looks on the ground to try to get positive programs pushed forward, or sort of what the barriers are.
Right. Again, because of this piece that knowledge brings accountability, there is a huge effort that has to be taken in order to get individual institutions, medical academic institutions, to even do studies along the lines of race for their own personal outcomes, or gender, or any other targeted demographic that you're looking at. Because if that outcome shows that there is a bias, if it shows that your Black patients have worse outcomes than your white patients, or your women have better outcomes than your men, then it brings about a stigma, and especially along the lines of race. I think that's been really highlighted. And so what it leads to is that because no one wants to take that spotlight, then no one can fix the problem, right? And we had a study that came out of the University of Virginia in 2015 that asked white med students and white residents, what are your thoughts about certain biological activities? So whether or not Black and brown people had different sized brains, whether or not there was a difference in fertility, did our blood coagulate or blood clot easier or less, were we more or less fertile? And what they found was that these white med students and residents were saying, yes, we think there's a biological difference, that we have different nerve endings, that our brain sizes are different. And then the second half of the study was to ask them, then if a person is presenting with this type of pain, how would you treat it? And what they found was that if you had those false beliefs that people are naturally born different, then you're 15% less likely to treat pain in an accurate way for Black versus white, right? So it has tangible differences. And some people may say, oh, well, that's just a study that, med students, and they aren't practicing yet. But there were studies out of, for instance, Florida, University of Florida presented a study where Black and white patients using the Medicaid database, they were looking to see if you presented and you had elevated cardiac enzymes showing that you were having an active heart issue, who was more likely to get a cardiologist assigned to them, who was more likely to have a study done on their heart. And statistically, it showed that if you were Black, or if you're a woman, and definitely if you're a Black woman, you were less likely. And it's just the reason why, even when you're presenting with chest pain, even when you're presenting with this enzyme level that says, yes, this person is having something wrong with their heart, those objective findings and subjective findings, is that the reason why Black people, Black women and Black men, are 29% higher mortality associated with cardiovascular disease, 40% higher mortality associated with neurovascular disease? Is this the reason why? Because even when we present with this, we're turned away. And we see this with COVID, particularly, that Black and brown people were less likely to be admitted to the hospital, therefore delaying treatment. And again, having outcomes of 67% increased mortality when adjusted for age. So it's not just that, oh, we are unhealthy, or we just have high blood pressure. That's pretty much almost ubiquitous with the United States of America at this point due to our diet and exercise practice. But it's not just that. There are the personal face-to-face interactions that come along with human beings being providers and human beings being the ones that work the system, and how do our biases play into how we interact with patients. So again, I think the problem is that no one wants to have that accountability tied to either their hospital system, their license, and so we don't collect that data. But I would push even further on thinking about the policy level too, when we talk about the CDC and how we wrote them saying we need this data. So the CDC had data that showed there are racial health disparities associated with COVID-19, that you were 6 to 8 times more likely to die if you're Black and brown versus if you're white. But yet when they wrote the policy for who should be prioritized for the vaccine, they left race out of it, right? They made it a race neutral policy, and they instead targeted age and said if you were older, you should be able to get vaccinated first, even though Black people and brown people have higher death rates in every single age category down to our babies. But they said if you're older, you should get prioritized. And then if you have a job, you should be prioritized, right? If you're an essential worker, if you're a healthcare worker, you should be prioritized. But what we know is that in those industries of healthcare workers, 60% are white, 16% are Black, 13% are Hispanic, right? If we're looking at the older age group population, if you are 65 and older, you're 77% of those persons are white. Only 9% are Black at 65 and older. We don't have longevity of life. So the policymakers that be saw that race and age were both independent risk factors for whether or not you lived or died because of COVID. And what they chose to do was to make a race neutral policy. And basing that, if you make a race neutral policy, what you do is in turn make it a pro-white policy. And that's exactly what we saw. And so when Ben was talking about the vaccine uptake, we see there's an inflection point around like June of 2020, when the vaccines were finally opened up to the general public that everyone can get a vaccine. You saw the Black community and brown community start to uptick at a much slower rate than white community did. And so at this point, we're actually matching the demographics of about 58 to 60% of the population in the Black community being vaccinated. But that's the problem, right? So again, it's not just collecting the data. We've had data for generations. It's about accountability and what do we do with it?
Yeah, I think perfectly said. And that brings me to my next question to Adam. You started to touch on this a little bit, but can you talk about how the current status of data collection really reflects and perpetuates imbalanced power dynamics?
Yeah, really good question. So for us, I would lay this kind of at the feet of something that Ben mentioned, which is number one, the way that policy or advocacy works, where the community perspective matters just significantly less. It's less effective than a data-based or data-backed argument. And when groups are left out of the data, or the wrong questions are asked of the community, or they're asked in the wrong way, where it's not culturally or linguistically relevant or accessible to the respondent, the observed, you end up with bad data, you end up with an inaccurate read of what's going on the ground, which then you're arming legislators, policymakers with, and then at the same time, you're, to the extent that issues are not being addressed on the ground as a result of this way of doing politics, you're forcing communities to look inward again because they don't see their issues being addressed by their representatives, by legislators and policymakers. So on one hand, there's a little, it could be a positive, right? Communities becoming more self-reliant, a little bit more industrial or entrepreneurial, but then it runs the other way as well, where they could become atomized or disassociated from broader national politics, and in a way that's ultimately damaging to, people like to make reference to something called the social fabric, right? So to the extent that a community may start off in this disadvantaged place, I mean, for our community in particular, many of our community members are immigrants and refugees, they're mixed status families. And then you add this miss or under recognition into the mix, you really do keep a community in a place of marginalization. and you fail to permit for them to see solidarity between themselves and those with whom they share a common cause or a common position in society. So for our community, we're, if you're making reference to low-income communities, you're making reference to our community, but we're not really considered in those policy conversations as such. We're sort of in this almost like liminal place. But the community, our community is located in major, I guess primarily concentrated in major metropolitan areas, which means we're part of very diverse communities. I would say rather invisibilized within those, and the way that I guess a data-backed political system is a significant factor in the kind of perpetuation of that state of affairs.
Thank you for that. Yeah, communities should not be forced to be resilient in every aspect of their lives. So that's sort of where this conversation is going today. I'm going to ask Ben one last question before we transition to what do we do now? Where do we go from here? And I'm thinking this will sort of guide us nicely into that. So Ben, you started to sort of give us an overview of how we got here, but can you tell us a little bit about the historical efforts we've seen to expand data collection and sort of where we are right now?
Yeah, and I think it's really important to put that in the context of what Adam and Ebony were just saying. When we're expanding data collection and the history of how we got to where we are today really is steeped in these concepts of let's actually recognize and not marginalize communities. Let's have accountability for policies and actually use data. And we've seen efforts for a long, long time for communities to fight for recognition through data in order to fight for the resources that can help them. And I think it also is important, right? Recognize that data that is not always used for good ends, right? Census has been the federal government's longest running data collection effort, and it was used to uphold slavery. It was used to incarcerate Japanese people in World War II. And right now, actually, we see the governor of Florida requesting data on how undocumented patients are using uncompensated care funds from hospitals. And so part of the fight for data is not only fighting for data, but for fighting that data is used in a just and accountable way. And so really that goes back to the Heckler Report in 1985, which really identified both for the first time that data existed and these disparities existed from the federal perspective right now for the first time. In actuality, disparities have been known for some time, but from the federal government's perspective, but also that there are huge data gaps remaining, that they couldn't draw conclusions around Asian Americans. And at that point, Pacific Islanders weren't even being broken out as a different category because of the lack of available data. And so the fight for both including categories that represent people's identities, right? The 1997 update to the standards that dictate what the federal government what data is collected through the federal government. Adam mentioned the Office of Management and Budget Standards included an expansion of categories, included Pacific Islanders and Native Hawaiians, and folks like Adam and others have been fighting now similarly for many years. It's been 25 years since those standards have been updated to being expanded. And really, we've seen Congress push in some ways for data to be collected. So the Affordable Care Act included data collection standards in Section 4302. And those standards were then made into regulation. However, the regulations are good under the ACA comparatively. They say that you have to collect primary language, which we haven't touched on yet, but I work on a lot. Primary language data is so important, and the ACA regulations require it. It requires disaggregation data, having checkboxes as a formula. It's something else we haven't talked about, but having checkboxes instead of bullets, right? Being able to select more than one racial identity is really important. And having subgroups, right? Not just collecting Hispanic or just Black or just white, but being able to identify as multiple categories. And for the census, actually the most recent census, that was really expanded to not just Asian Pacific Islander groups, but other categories of white. And as a white person, right, I know that if we are only collecting identity on just white, we're actually upholding white supremacy, because I am not white or even just white, depending on your perspective, right? I am German, Irish, and Ashkenazi Jewish. And by asking people if they're just white, we're upholding this identity of white, which is as much a myth and creation as anything else. But the problem with the ACA standards is that, and this is where we really get to where a lot of the fights are about data equity, the ACA standards and what the law said is that you didn't have to collect the data if funding wasn't available. And so the federal government is not required to collect disaggregated data if funding is not available for that data collection. So we don't require disaggregated data collection in COVID or for people, identifying who enrolls in Medicaid or uses different programs, because right now that data is pretty much usually just used in surveys. And we use the survey data a lot. The National Health Interview Survey, the American Community Survey, which use those ACA data collection standards, are good, but we need programmatic data, which is in some ways even more reflective of reality than just survey data. And so we see fights like in 2016, there was actually a proposal that was going to change those Office of Management and Budget standards, that was going to include a new MENA category, that was going to standardize and require disaggregation of at least Asian and Pacific Islander categories, that was going to eliminate pretty outdated terminology that is used to identify Black people, and to really potentially combine race and ethnicity into one question. So we don't have folks who are Latinx or Hispanic checking some other race a very large percent of the time, because their race is an ethnicity and the kind of the way society treats folks who are Hispanic versus people who are other races. And the Trump administration killed it. The Trump administration killed that attempt to update the data standards. And so now we see the Biden administration, rather, having a data equity framework, a data equity working group that just came out with some initial recommendations a month ago. We see the president issuing executive orders saying data, which is really good. But I think we're really watching now to identify what changes are actually going to happen, and meanwhile continuing to push for resources, continuing to push the federal government to go beyond its own minimum standards, and to really also look towards what is needed beyond just the federal government, but like I was saying before, what training is needed, what resources are needed, updating IT systems. We haven't kind of talked about medical record standards, but those have long been a way of pushing this forward. And so that's a lot of where this work is happening, but it's really been grounded in community. It's really been pushed by the communities of color, by the folks in the LGBTQ community, by the folks in the disability community, who are saying we need resources and we need recognition, and you really need to be doing better to push for data to be collected on us at every level. And so it's a really short way of putting it, but this work has been going on for a long time. I know there's been a lot of attention going to it because of COVID, and COVID really threw so much of what's going on in our country in terms of racism and disparities into light, but this has been happening for decades.
Thanks so much for that overview, Ben. And I really like what you said about this work being grounded in community. We know that collective liberation cannot be achieved without a community-centered approach. So it's critically important to apply that to equitable data collection as well. So we're unfortunately almost at time, so I'm going to do our last question for our fabulous panelists before we turn to audience Q&A. So we've heard a lot about where we're at right now, what the gaps are, and what the issues are. But where do we go from here? You all are experts in your fields. What are some recommendations that we can now turn into action? So we're going to start with Adam, go to Ben, go to Dr. Hilton, and then end with Pilar.
Yeah, I would in fact start with something that Ben referenced, which is establishment of a data collection category for Middle Eastern or North African individuals as part of disaggregated data more generally. And then as well, I would include reform to programs that make effective reference to those racial and ethnic data collection categories. So For instance, the racial and ethnic minority group definition authorized in the Public Health Service Act to shape the scope of focus for the Office of Minority Health. We submitted a minority population profile using available research on MENA communities, which we believe puts us on a par with other racial and ethnic minority groups that the OMH recognizes. And then that should reflect in their authorizing legislation. And the same goes for other definitions that agencies like the Small Business Administration use to target federal support for small business or minority small business concerns, and then other agencies as well. But again, this being part of a systemic reform that stems from the role of data collection categories in assessing and addressing social problems.
So we really need to, in addition, when we get those categories changed, when we normalize it, ensuring that the resources are put in there, not only so that the data is collected, but the data can be analyzed and reported. And so that means, for example, potentially oversampling populations. Often small groups like Pacific Islanders or Pacific Islander subgroups or American Indian and Alaska Native populations, groups that are very present in our country, but are just statistically smaller in numbers. The excuse often is, well, we can't collect that data or we can't report that data because of statistical significance issues or because we worry about privacy issues, which are important. But there are answers, right? It requires funding. It means oversampling and it means standardizing that approach. So it's not just a one every 10 years sort of thing. It is that in every sort of survey, we do it. When one thing we do at the National Immigration Law Center is we co-run the Protecting Immigrant Families campaign, which has really responded to attacks on immigrants and public charge. And we did a survey of immigrant families about their experience with the public charge rule and oversampled from Asian American populations in language because it was important to be able to accurately represent those populations. So it means not only collecting the data, but normalizing practices that allow it to be reported and in a public way. I also talked a lot about how we need to make sure that people who are actually doing the data collection are doing it correctly, that the data is being asked in a way that makes patients or vaccine recipients or what have you comfortable in filling it out. Means that people who are doing the data collection understand that it is important and that they're actually incentivized to report it, not just skip it over if they're having a busy day or not include it in their reporting mechanisms. And so that means we need to have both adequate training and oversight. We need to have roles within the federal government, within state governments, whose responsibility it is to actually see whether the people who are supposed to be collecting and reporting data are actually doing so. Otherwise, we may as well not have the standards at all.
And is it me now? I didn't know which order. I didn't want to go out of turn. Yeah. So I think there's a huge lift we can do, and then smaller things along the way. So when I think about like short-term goals, I think it's just literally saying that if there are any federally or tax-tied dollars associated with a program, then we can mandate that it has to have data collection along the lines of race, gender, and any other tangible identifiers. I think that's just the right thing to do, but I think that should be an easy thing to do. Again, if you're taking our taxpayer dollars from every single citizen in the United States of America, then they should be able to have the right to know what you're doing with those dollars. I think then in terms of midterm goals, we should look at how do we create a national dashboard, national, you can go state, you can go down to local dashboard that's public facing, and easily digestible. None of this stuff that we put on the CDC, which takes a PhD in order to understand it, but truly that is easy to digest by the general public so that people actually know what's going on. But I think in terms of like long-term goals that we should have established is we keep saying we need accountability. Why do we not have a Department of Equity on the federal level? Right? We have a Department of Defense, Department of Education, Department of Transportation. If we know disparities exist across the board, regardless if we're talking about race, gender, religion, language, and again, if we're all tax-paying citizens, then shouldn't there be a department that is dedicated to looking at every single policy that comes out of the administrations with an equity lens to say, is this or is this not unfairly targeting one population, or targeting one in a favorable way, right? If we did that on the federal, the state, and the local level, if you had a Secretary of Equity that has to go and make a report for the public to see, then maybe we can start to shift these policies and actually have an impact on the capillary level of community. But yeah, that would be my short-term, midterm, and kind of long-term fix.
Just FYI, I'm definitely incorporating the term capillary level into my next brief. I need to look that up. That sounds really nice. So from our perspective as lawyers at the Lawyers Committee, there is no data collection if people are unable to access the healthcare system. It's kind of like your uncle who keeps his money in a mattress. People, if they're sick and they can't get to the doctor, well, all the things that we're talking about are moot. There's no need for accountability if half the community is not even accessing the system. So for us, that means eliminating barriers to healthcare. That means, for example, Medicaid expansion, closing the coverage gap, making sure that people have health insurance so that they can actually afford even just their yearly wellness visit. That also means policies like paid sick leave, universal paid sick leave. There are reasons why people, even who have health insurance, don't go to the doctor. And it's because they have barriers in their employment status, which is another reason why we need employment status data alongside insurance data. It's not enough to say, do you have insurance? Well, maybe you can't even use your insurance to go to the doctor because you don't have paid sick leave where you work. That also means just generally addressing discrimination in healthcare and making sure that Section 1557 of the Affordable Care Act is robustly enforced, and that we have the available enforcement mechanisms, those tools really readily available and for lawyers and policymakers to stand up. And so I think I just say all that to say, that's the work that we will be focusing, that we do focus on, is to make sure that there's even a way for people to get to the doctor to provide their data, provided all the other things are right. This piece over here has to be intact as well.
Thank you all so much for sharing your brilliance. I know I've learned a lot from this panel, so I'm sure our audience has as well. We've got about 10 minutes left. We have a bunch of audience Q&A questions, so we'll try to get through a couple. And I know our president and executive director will be joining us shortly, so we'll leave some time for him to close us out as well. So let me see in our Q&A. So our first question, the person mentioned they appreciated the historical context that Ben provided and was curious if you could share any particular historical accounts that have influenced your work, particularly around the social construct of so-called Asian American community. So Ben, if you could follow up with that in the chat, that would be great, and type out that answer. Our second question is, can community-based participatory research help engage the public in becoming more knowledgeable? I'm not sure, Dr. Hilton or Adam or Pilar or Ben, feel free to jump in.
I think certainly, right? But I think it's when we say community-based participatory research, oftentimes we expect the community to respond to us, right? We send out surveys, which I think people now are survey fatigue because they've been surveyed for generations and nothing has changed within their community. So it's one of these, why are you asking me if you're not going to do something about it? So how are we collecting the data, for one? Are we truly going to the source of the people, or are we putting it on the internet like we did with vaccine registration, right? When we know that that's not a luxury that unfortunately a good majority of Americans have. So how are we defining what community is? And then how are we actually going out to engage those persons and truly asking questions that matter too? I think sometimes we have these blanket statement questions, and it's touching on, again, the symptom, of the problem. Did you go and did you visit your PCP within this year? Yes or no? And it's like, well, no. it doesn't get to the fact that, well, because I was literally homeless and bouncing from home to home to home this year. I was, it doesn't dig down to the root cause of what causes that that impediment. It doesn't touch on, I don't go to the doctor because I don't trust them because of this, and this, right? I think surveys, they have a purpose and they do a great job of what they do, but I think they're limited in the ability to truly touch the vein of what's happening on the ground level, which leads me to say that, but that's why I think with every single panel, committee, policy body that's coming together, you should have a representative of that community that is the most marginalized of the most marginalized person, not to ask them questions, but literally to sit on the board, to talk about what is the lived life experience of being a single parent who is threatening homelessness and struggling with having to go to food banks. That person needs to be the person that you're having the voice at the table, that you pay them for their participation. Don't ask them for free information, but also, like I said, not ask them one time in a survey and then that's it. It's like we need that constant, how do you say it, stream of life lived experience placed into the policies that we create.
I think, and I cannot remember the formal title of these panels, but when we were digging into the, like which states were doing what, we learned that certain states like Illinois, they had panels with community members, people like from various universities, like HBCUs, people that really represented the voice. I think there were like health equity panels. I just don't recall the formal name. And they were actually very useful, and they met regularly, and they made recommendations to the public health directors. And so they were impactful to the extent that they were being used during the early days of the pandemic.
I'll just quickly add on this because I think I've had a couple of conversations with community-based folks on the census, and they kept asking, why should we reach out to folks on the census? What is the census doing for us? These questions don't seem to be designed to help our community. So at every level of, not just how you distribute surveys, but what the questions are and what they're trying to get at needs to be involved if you really want to get the community perspective.
And I'll just echo what Ebony said about the kind of fatigue from communities, given the propensity for this data collection to occur without follow through. And for us, that issue is acute for reasons we have discussed, but that really holds true for a lot of other communities as well. So just wanted to echo what Dr. Hilton said there.
Thank you all so much. We are at time. I know we have a bunch more questions from the audience, which just speaks to how critically important this conversation is. So I'll be sure to pass along these questions to our panelists, and we'll figure out a way to get the answers to you all, as well as sharing the recorded presentation. With that, since I want to be respectful of folks' time, I'd love to turn it over to our President and Executive Director, Damon Hewitt, to close us out.
Thanks so much, Natasha, Pilar, and our esteemed guest, Dr. Hilton, Ben Adam, and all of our audience members. We appreciate you. The COVID pandemic has taken so much from so many of us, and we know that many communities have been hit disproportionately. We have an obligation, a duty to not just understand what's going on, but to use the power of information to the advantage of the people who are most directly impacted. Now, I could say that for any context, whether it be voting, policing, what have you. But we know that in the midst of a structural racism, which is really what we see in this country all the time, we see that what happens with communities of color is that you get the short end of the stick. And so we have to work harder and pull out all the stops to make sure we have access to the right, accurate, and reliable information, but more so to put the policymakers and even those in civil society, the health systems, providers, what have you, on notice that they can, they should, and they must leverage that data for good. We're living in an era of big data all around us. Sometimes people treat us as if our data is more valuable than we are as people in our lives. If data is going to be used that way in the private sector, which we challenge all the time, we should at the very least make sure that data is used to the advantage of communities to keep people healthy, safe, and frankly, alive. I said this pandemic has taken so much from us, it's taken a lot from me. So many of our staff members who have been touched, who have been sick, who have lost loved ones, and you in the audience can probably say the very same. We know what we have to do in this country. And I so appreciate our team and the great speakers today for their leadership, for your vision, and for your heart and your hard work and leading the way to make that happen. Thanks so much for being with us in this fight. Thank you, Natasha.
Thanks so much, Damon. And thanks again to you all for attending. We will follow up with answers to all these fabulous questions, as well as a recording of the presentation. Just want to give a quick round of applause to our fantastic panelists. Your brilliance has been just so inspiring, and I'm looking forward to all the good that comes out of this conversation. So thank you all and enjoy the rest of your afternoon.